Banerjee. So I am going to
Recording in
introduce.
progress.
I'm going. Can you hear me?
So you need to start now because I think now it's 8 o'clock. Now 1 more minute to go, and then you can start. Ashwin, you need to tell sir when to start.
Sure.
Okay. Sure.
Yeah.
Team, I think you can just help us when to start, when we are going live, so that Dr. Banerjee can start the procedure.
Yeah, we can start in 30 seconds.
Okay. Just tell me when I should start.
So just count down 3, 2, 1, and then Dr.
The Cardiological Society of India. I am Professor P.S. Banerjee, immediate past president of the Cardiological Society, and I have the pleasure to say this is a very important webinar, which will be discussing by none other than our present president, Dr. Vijay Bang, and the subject is very important. With me is Dr. Kabra, who is the convener of the Lipid Sub-Council of the Cardiological Society of India. And the topic is secondary prevention of coronary artery disease. And you all know this is very important subject to discuss because this is still a neglected one because of the lack of awareness among the population. So also there is a communication gap, and also the poverty and low socioeconomic conditions, all important. But we all know that if it is being followed using the modern technology, socioeconomic upliftment, as well as the artificial intelligence, digital technology, all we have the greater participation in the long run, so that the adherence to the secondary prevention from coronary artery disease will.
I'll take over from Dr. Banerjee. As is well known, about 20 to 40% of all acute coronary events or acute cerebrovascular events occur in those people who already have an established vascular disease. And if you take a person who already had an acute coronary syndrome, his chance of developing an acute coronary syndrome or cerebrovascular event is almost 5 times more when compared to a person who does not have an acute coronary syndrome. And the silver lining is that by secondary prevention, we can prevent about 75 to 80% of the secondary events can be prevented. So I'll request Dr. Bang none other than the president of CSI at present, take over and enlighten us about the latest advances in the usage of antithrombotic therapies and statins and lipid lowering therapies in secondary prevention. And I'll also like to add that secondary prevention is a very wide and deep subject. So we have none other than the president himself to go into some aspects of that. And thank you. Over to you, Dr. Vijay Bang.
Thank you very much, Dr. P.S. Banerjee, Dr. Kabra, asking me to begin this topic, newer advances in secondary prevention, atherosclerotic cardiovascular disease using lipid lowering and anti-thrombotic agents. As we know, that secondary prevention is more challenging than primary prevention because patient already has a disease. So as per ASCVD score, he falls in the very high risk category. All these patients fall in very high risk category to begin with. And we have two aims with secondary prevention. One is to prevent morbidity, mortality of cardiovascular disease and improve quality of life. And we have three ways to manage it. One is pharmacological intervention, non-pharmacological intervention, and specific preventive strategies. All these three are very important, but today we are going to discuss a pharmacological intervention in terms of lipid lowering and antithrombotic effect, how it lowers the secondary events. Can I ask the tech to put this bar on the side, please? Because it's obstructing my slides. Hello?
Sir, you can drag wherever you want to, sir. You can
No,
drag.
but how can I drag? It's a whole screen is occupied with the slide. If it is not seen, then there is no. Can you just not put this off?
Sir, we are unable to see, sir. We can't
Sir,
see.
like
It is
what you
fine.
can do, sir, what you can do is go to on the right upper corner view, and if you go to view, you'll have standard side-by-side speaker and side-by-side gallery, sir. And exit full screen, sir. If you exit full screen, you will get the bar, sir.
Kabra, we all know, but there are 5 people we cannot accommodate on the slide.
Yeah, there are so
No,
many
sir,
people, sir,
sir,
but I think
sir,
they don't
you
have
have
the
to-
control of your computer, sir. That's why.
Sir, you have to select a speaker view. Speaker view. There is a column. You have to select a single one. First option. On the top of the window, you have to select first option.
That's what I'm trying to see. But the entire thing is completely obstructed by so many people present here.
Yeah, that is from that setting has to be done from your side, sir. So the on screen,
let me now start whatever it is. I am unable to understand this because anyway, now as I said, that secondary prevention is more challenging because of the residual risk. What is the residual risk? It could be inflammation, which we all know that if inflammation is there, the atherosclerosis is very active. And we can identify that by doing a HSCRP. Residual metabolic risk in terms of LPA increase, diabetes risk, and triglyceride increase. These are all very important one, especially the LPA. We have no good drug till today to control LPA. And another thing is the balancing ischemic and the bleeding risk with the use of anti-thrombotic agents. And now we have several trials in that respect. I will cover one by one. Let's move forward. I'm unable to change my slide.
Sir, kindly double click on your slide, sir. Kindly double click on your screen. Double click. Yeah, it's moving. Yeah, moving.
This is so terrible, I tell you. This technology, I don't want technology support, actually. So, coming to the triad of diabetic dyslipidemia that we see in India, a very peculiar type of dyslipidemia. Increase in triglyceride level, reduced HDL-C level, and LDL-C, though normal, but small dense LDL is predominantly increased, and reason being insulin resistance. Insulin resistance activates the CATP pathway and converts LDL predominantly into small dense LDL. Large dense LDL into a small dense LDL, which is more atherogenic. So it's not only LDL which is atherogenic. In fact, if you go to see, entire non-HDL is atherogenic, which we call ApoB also. So non-HDL and ApoB, they are identical. There's no difference. And what it contains? LPA, LDL, VLDL, IDL, and chylomicron remnants and chylomicrons. So all these form non-HDL cholesterol. Why it is important to say that? So as non-HDL cholesterol crosses 130, we can see there is increase in hazard ratio, and which is reflected with cumulative cardiovascular disease incidence over a period of 30 years in men and women. We can see as the non-HDL cholesterol increases, the risk of incidence of coronary artery disease risk increases. So it's not only LDL. Reducing non-HDL goal is also very, very important in terms of secondary prevention. If we don't tackle both, secondary prevention can never be achieved. So what are those goals? We are talking of very high risk, because already we are talking of secondary prevention patient who already have established ASCVD. So LDL should be less than 50 and non-HDL cholesterol should be less than 80. This should be our treatment goal for secondary prevention in terms of lipid lowering. In India, Lipid Association of India has recommended additional category because of the high risk of coronary artery disease in Indian South Asians. The extreme category is A and B. And it recommends that in category B, the LDL cholesterol should be less than 30 also. That is beneficial in reducing second event after having a coronary artery disease. This is difficult to acknowledge because so far we thought low HDL do cause increased independent risk factor for coronary artery disease. But high HDL we thought is a protective, but above 60 HDL is not protective at all. Not protective. Please remember this. In fact, it can lead to infectious disease, autoimmune disease, lung disease, cancer, diabetes, and kidney disease. So, important drug that is available today, we all know, is statin. And statin, we know it inhibits HMG-CoA reductase and somehow the other blocks the further production of LDL-C. So how it happens? If the plaque, if LDL-C reduces, it declipidates and stabilizes the plaque. Before statin, you can see a large lipid layer or plaque, whereas after statin, the plaque has reduced considerably and there is fibrotic change. And this has been documented by non-invasive techniques, MRI, NIR. All these techniques have shown that statin reduce the hot plaques, vulnerable plaques, into a normal plaque. And we can see it here, a lot of LDL. After statin, it's all calcium now. Second effect is, we all know that it's a pleiotropic drug, improves endothelial function, reduce inflammatory response, stabilizes atherosclerotic plaques, reduce a thrombogenic response, inhibit vascular smooth muscle cell proliferation, and also inhibit cardiac hypertrophy. That in turn reduces the myocardial oxygen demand. So we all heard all these things, but I would like to particularly emphasize that it also decreases thrombogenicity. So if suppose a patient of STEMI presents or ACS present and he's already on statin, he will do better than patient who's not on statin. So having statin for primary prevention, secondary prevention is of a great help, whether LDL-C is high or low, doesn't matter. So we all know that it converts the vulnerable plaque into stabilized plaque. And if we continue statin for 20 years, Voskop's legacy effect has been, Voskop's trial revealed legacy effect. And it has been further enhanced by none other than our legend, Dr. Brownwald, that if you continue to have from age of 20, LDL less than 70, you can live up to 100 years. And further studies have shown, can it stabilize the plaque? Yes, universally accepted that statin therapy stabilizes the plaque. Can it reduce the plaque? Yes, reversal trial using atorvastatin clearly depicted that it reduces the plaque burden. Can it shrink the plaque? Yes, Glagau trial using statin plus evolocumab, that is PCSK9, regresses the plaque or shrinks the plaque. But can it disappear the plaque? No, so far this issue is unresolved. So how long do we continue the statin to get the perfect benefit of statin? Minimum 2.5 years. But if you continue for several years, the benefit continue to increase. Very important fact. So statin, we all know, is inexpensive. It can reduce, it's safe. It can reduce LDL-C by 60%. And importantly, it reduces the MACE by 50% over 3 to 5 years. And reduce mortality in men and women, individuals with low or high LDL-C, doesn't matter, or primary or secondary prevention. A very interesting one. So we have new drug now, bempedoic acid, which is also equally good drug. And wherever we don't have a statin alone is not able to produce, cannot achieve the goal, we can add bempedoic acid. It reduces further LDL-C by 15% when it's used with the statin. It has been proven by Clear Harmony and Clear Wisdom trial. Whereas if patient is statin intolerant and only bempedoic acid can be used, we have this new drug which can be used in place of statin. And Clear Tranquility and Clear Serenity has clearly shown that it can reduce alone along with the statin, it reduces 15% LDL-C, but alone it can reduce up to 25% LDL-C. And when we add ezetimibe, it can go up to 35% in absence of statin. It also reduces HSCRP. HSCRP along with the statin, it reduces about 18 to 22%, whereas alone in patient, if patient is statin intolerance, we give bempedoic acid as alone, it reduces 30% and more. So if you are unable to achieve the goal alone with atorvastatin, you can try this combination of bempedoic acid 180 milligram, ezetimibe 10 milligram, and atorvastatin. We call it a triple combo, oral therapy. 90% of the patient achieve LDL-C level of less than 70, and 58% patient achieve LDL-C goal of less than 55. And the change is almost 63% with this combo in LDL-C, which is much better than 50-55%. So what is the statin intolerance incidence? Approximately 9%. But we don't see that much in the clinical practice. Important is when you have any patient complains of statin intolerance, myalgia, you should check vitamin D level. Correct vitamin D level, myalgia will disappear. I have observed this in my clinical practice, and it is also a proven fact in literature. Similarly, if you have a patient who's complaining of statin intolerance, check thyroid. If he has hypothyroid, correct it. The statin intolerance will disappear. So both in vitamin D deficiency and hypothyroid, it can disappear. But you should never discontinue the statin because the statin effects are so high. Switch to another form of statin. If patient is intolerant to one form, change to another form. Lower the dose of the statin. And alternate day dose. I tell you one very important fact about alternate day dose. The effect is same, whether you take daily or you take alternate day. It is proven by the science and it's there in the literature. Effect is same. Or you can try polypharmacy. But problem, why I said never discontinue statin. If statin continued, it reduces the event rate and mortality in MI considerably. No statin has a more MI and more mortality. But if statins are discontinued, MI mortality increases, is a rebound effect. So don't forget this, never discontinue statin immediately. And whenever you have intolerance with statin, the newer 2009 drug, pitavastatin along with ezetimibe and bempedoic acid, is excellent combination for patient who cannot afford PCSK9. PCSK9 has financial constraint, especially in country like ours. Although I have very low threshold for use of PCSK9 on my patient, especially for secondary prevention, and all patients who have LPA increase along with LDL-C is the best drug to use currently available in the market, but expensive and requires injection twice a month. Statin in elderly. if we discontinue statin in elderly, it increases both MACE and death, both. So never stop statin, and statin is clearly in secondary and primary outcomes are superior with statin even in elderly. So all these trials of statin have shown that primary and secondary prevention, both, it is lower the better, the more prevention. More lower the LDL, better it is. Statin in pregnancy can be used, no increase in congenital abnormalities, but definitely the birth of the baby, preterm delivery can be there, or birth of the baby may be reduced. So if we have a triglyceride, like Indian typically have triglyceride increase due to insulin resistance, and we use icosapent, and icosapent trial, REDUCE-IT trial, has clearly demonstrated that it reduces the event significantly. And it reduces first event by 25%, second event by 32%, third event by 31%, and fourth event by 48%. And it's available. Icosapent is available in India, and we can use that. Very useful. Now I'm coming to PCSK9. It reduces MI and death if we use in acute MI patient who has high LDL level and not controllable, and it clearly shows the benefit is there. Now, this is a new drug which is available and commercially available in Europe and America, and is US FDA approved drug. It is siRNA, means small short chain or small chain mRNA, small chain RNA drug, which reduces PCSK level in the overall system. And the advantage with this drug is like a metabolic vaccine. The effect give once in 6 months, 2 injections, and effect, it continuously lowers the LDL-C level less than 50, and it continues till 510 days. 365 days is 1 year. 510 days it continues. So Orion, if we pull the data of Orion 9, 10, and 11, it clearly shows that it's very beneficial drug, and it's remarkable and new invention, which is extraordinary drug, but expensive again. So initial dose of 284 milligrams subcutaneous injection, repeat another dose after 3 months, and then twice a year, 6 monthly. And it is currently approved by FDA for heterozygous familial hyperlipidemia and clinical ASCVD who require additional LDL-C level lowering. So this is very good drug available internationally, and I think it's available in India and imported by some company, but distributed by some company. Coming to LPA, the most important is identified as an independent risk factor for CAD secondary prevention. Also, if LPA is elevated, we have seen the patient coming back again with recurrent events. So PCSK9, 25-30%. Inclisiran also reduces 20 to 60%. Otherwise, we'll require lumetriptyide and niacin. Of course, niacin 20%, very cheap drug. And I use niacin in my practice. I see no hot flushes, nothing. NF niacin is available and it's very safe. We can use 1000 milligram in patients who have over a period of time. It doesn't come down easily. Over a period of, you continue for 1 year, LPA come down significantly. So LDL apheresis is very expensive. We need to do it twice a month. It costs about $3,000 to $4,000 US dollar. In India, I don't think we do LDL apheresis. So newer drugs have come and they are very translational. Pelacarsen reduces LPA by 80%. Olpasiran reduces by 90%. And both are very safe drugs. And soon they will be soon FDA approved, CE approved soon, because they're already applied for approval and they're remarkable translational drug. It is going to be in the clinical practice without any doubt. How it acts? mRNA, microRNA, and it reduces LPA. Now, it doesn't reduce only LPA. It also reduces the LDL-C, and LPA reduction is 67%. It's a remarkable drug, and dose is 80 milligram per month of pelacarsen. Now, another risk factor I told you, non-HDL-C, if it doesn't reduce by available oral drug therapy, then we have to go for some newer drug. Research has come out with a microRNA drug, vupanorsen. And vupanorsen effects are remarkable. It reduces with 80 milligram dose, 44% and 69% of angiotensin-like 3, which is supposed to be significant parameter to reduce, and LDL-C and ApoB reduction. So if you increase the dose, the decrease in all risk factors related to lipid cardiac disease. Now we are talking of newer advances. Newer advances, SGLT2, have been tried in secondary prevention, and 3 trials have demonstrated that it reduces the event by EMPA by 691 events reduced over a period of 3 years. Over a period of 6 to 7, 420 events reduced by canagliflozin, and 1390 events, almost 1400 events reduced in 4 to 5 hours using dapagliflozin. So SGLT2 is playing important role. It's like statin, which has a pleiotropic effect. And similarly, glucagon, like peptide 1 receptor and agonist used in diabetic patient, reduces all-cause mortality and very effective in diabetic patient. So if you have a CHD and diabetic patient, CAD and diabetic patient, as best is to use these 2 drugs, SGLT2 and GLP-1RA drug. And in combination also, there are several positive effects, and they can reduce, can be useful in secondary prevention. If still the hsCRP remains high, despite high dose of statin, because we all know CRP reduces with statin, we can try colchicine, particularly in acute MI, and secondary outcome also. Numerically, it is superior to placebo, but statistically not significant. CANTOS trial using canakinumab is supposed to reduce again CRP level and reduce the MACE by 27%. So we have several drugs. All drugs act on liver, and even lipids are produced in liver, we all know. But why I've put this across is the genetic editing. It is already begun in New Zealand, and one case has been reported successfully. It's one done and good forever. So in future, we might see a genetic editing, and that's it for primary and secondary prevention of CHD, particularly useful in familial hypercholesterolemia. Now coming to anti-thrombotic drugs, let's see what guideline says. Secondary prevention. So suppose you have a patient who's got ACS and he's on DAPT, you continue for 12 months if there is no contraindication of risk of excess bleeding. Then prolonging antithrombotic treatment duration more than 1 year in ACS, you can do it, provided if there is high ischemic burden, but low bleeding risk, you can consider DAPT for longer than 1 year. Similarly, if the moderate ischemic event and less chance of bleeding risk, you can again consider for longer time. And some patients, if there is no history of prior stroke or transient, we can consider, if patient has atrial fibrillation, we can consider adding rivaroxaban 2.5 BID as per the Composite trial. So one side is a long-term therapy, other side, if bleeding risk is high, ischemic burden is high, other side bleeding risk is high. So you have to shorten the DAPT. And that depends on, you have to evaluate precise DAPT score. If it is more than 25, you can give ultra short or short duration of DAPT. Ultra short is 1 month and short is 3 to 6 months. And this also is a good strategy and supposed to be effective. A lot of trials have already been done and they have shown. So what we need to do in DAPT, in considering antithrombotic treatment, we have to see the clinical aspects of the patient, the age, sex, race, history of ischemic event, bleeding events, clinical presentation, chronic coronary syndrome, ACS, CKD, diabetes, peripheral vascular disease, heart failure, co-medications which can increase or prolong the effect of anticoagulant drugs or antithrombotic drugs, procedural aspect, PCI, CAVG time. So all these aspects we need to take into consideration and create a perfect balance between ischemic and bleeding risk using precise DAPT score or DAP score. And we know DAP score and DAPT score, we are all using it. If patient has undergone a PCI following stable coronary artery disease or acute coronary syndrome, the standard drug therapy, if high bleeding risk is not there, then DAPT to be continued for 1 year, and combination is aspirin plus clopidogrel, class 1A. You can continue for longer if there is no problem. If there is a problem, you can shorten it. If the bleeding risk is high, then ultra short duration of 1 month of DAPT and then continues SAPT. 3 months is another option, again using in stable coronary artery disease, using aspirin plus clopidogrel. If you have an acute coronary syndrome, you have to use preferably either prasugrel or ticagrelor. If no high bleeding risk, then 12 months is preferred. If high bleeding risk, 6 month DAPT. Maybe you can, instead of prasugrel, you can try clopidogrel. And we can continue more than 12 months if patient has high ischemic burden. Several DAPT trials have been done using shorter duration, ultra short duration. And TWILIGHT is a very interesting trial and very important one. Says that ticagrelor alone, rather than ticagrelor plus aspirin, in complex PCI, in very complex disease or high ischemic burden, if you go to see, ticagrelor arm has less cardiovascular death, MI, all-cause death, MI, ischemic stroke, and stent thrombosis. So alone, ticagrelor is supposed to be better in TWILIGHT trial. What is the bleeding risk? with the placebo alone ticagrelol, 4.5% may have bleeding risk if they fall in 3 to 5 bleeding risk criteria. And 1.1% to 3% if it is low bleeding risk, 12-month randomization. So ticagrelol alone is good enough if you have even a complex PCI, which is very good for all of us. And we can, even I tried in my clinical practice, and I agree with this finding of TWILIGHT trial. Now, based on the type of drugs used on drug-eluting stent, everolimus or zotarolimus, everolimus, zotarolimus, or biolimus. And this has shown that the MACI at 18 months using various forms, and it's shown that the ticagrelol along with aspirin is better DAPT than ticagrelol with clopidogrel. So current guidelines recommend that prolonged DAPT in ACS is very important. Otherwise, if you stop prolonged DAPT of 1 year in ACS, you will have recurrent MI, and you need to use ticagrelol. Clopidogrel and prasugrel also reduces MI, but more potent with ticagrelol. Almost ticagrelol and prasugrel results are almost identical. So no doubt meta-analysis study has been done, and it has shown that aggregated results showed that no increase in major bleeding risk using ticagrelol, and ticagrelol may be valid, even more potent antiplatelet drug than clopidogrel, especially as an alternative strategy in treating patients with clopidogrel intolerance. We all know clopidogrel has very genetic cause of intolerance. Platelet aggregation, the minimum platelet aggregation is observed with ticagrelol compared to prasugrel and clopidogrel. Same thing that is depicted, prasugrel and versus ticagrelol tablet study. So what is data suggesting? That ticagrelol significantly reduced cardiovascular and all-cause mortality compared to clopidogrel. No statistically significant mortality reduction with prasugrel, clopidogrel, almost significant, similar. So compared to clopidogrel, both prasugrel and ticagrelol are definitely superior in patients with ACS, and there is no significant difference in prasugrel-ticagrelol outcomes. But very interestingly, Composite trial. We know that Composite trial, rivaroxaban and aspirin alone in another arm. And when it compared the results with the lipid-lowering agent, BP-lowering agents, and S inhibitors, what it says that there is in triple outcome and death and stroke, Composite rivaroxaban with aspirin is superior to lipid-lowering BP and S inhibitor. So this is very interesting finding, and we should look at this angle in selected patients. If ticagrelol patient develops spontaneous bleeding, you can reverse the effect of ticagrelol, particularly if patient is going for surgery and you want to reverse the effect of ticagrelol. No need to wait for 3 to CABG, and you no need to when you are already loaded before angio, and patient wants to go. Patient has to go for CABG as per the severe disease. Then you can reverse the effect of ticagrelol using this PB2452 drug, and very effective in using it. I think is not available in India, may be available, I don't know. So what is evolving concept in terms of anti-thrombotic therapy? We have to divide this patient in 3 categories: stable, ACS, and high ischemic burden. So if patient is stable, 3 to 6 months DAPT, the bleeding risk is high, you can reduce to ultra short DAPT 1 month in stable patient. If precise DAPT score is more than 25, you can again use short duration 3 to 6 months. If it is less than 25, you can use it for 12 months. Same for ACS. DAPT score, if less than 2 and more than 2, you can use, depending on that, a DAPT score. But in patients with high ischemic burden, we can try rivaroxaban with single antiplatelet agent, SAPT. It seems to be more sensible approach and should be considered because it reduces PAD, stroke, and the coronary artery disease. So in conclusion, short duration of DAPT as a routine therapy is absolutely no problem in patients with high bleeding risk. And it can be ultra short, 1 month. Current angle of aspirin-free therapy using only clopidogrel or P2Y12, one of the P2Y12 inhibitor drug seems a good approach, and aspirin monotherapy against clopidogrel monotherapy has been tried and seems to be safe and effective. In complex PCI, we have to go according to exact bleeding and balance the high ischemic burden against the bleeding risk and continue it for a longer time if you have ACS. Thank you for your kind attention.
Thank you, Dr. Vijayabang, for such a nice exposition of the advances in lipid therapy as well as antiplatelet therapy for secondary prevention of coronary artery disease. You have taken us through the whole gamut of lipid-lowering therapy, starting with the importance of non-HDL cholesterol, and then the additional categories of the Lipid Association of India, and the change in paradigm with the HDL cholesterol, and the effects of statins on plaque stabilization, calcification, and the importance of triple combination with the bempedoic acid, statin, and ezetimibe, and also the importance of lipoprotein A, and ending with the very, I think, wonderful future of gene editing, which has already started in New Zealand and this one. And they also covered very well the DAPT score and the high bleeding risk as well as the high ischemic risk in patients vis-a-vis the complex PCI and all. Thank you so much, sir, for covering the entire spectrum for secondary prevention of CAD. And to keep in proper perspective, I would like to say that we have not covered beta blockers and calcium AC inhibitors or ARBs in this lecture, because this was actually devoted only for statins and lipid-lowering therapies and antiplatelet agents. And of course, cardiac rehabilitation also has a very important role to play in secondary prevention, but that may be for some other talk in the CSI webinar series and that way. So over to you, Dr. Banerjee, for your comments. And
yes, Dr. Bang, very good disposition of the topic. So you have covered already most of the part of this topic. As said by Dr. Kavra, yes, there is a significant role of beta blocker and ACE inhibitor, particularly the patient with having the low ejection fraction, in the further improvement in the outcome in the secondary prevention. Now, my question to you, now besides these medicines or other parts, what you have discussed already, now what is your comment of using the digital health tools in the secondary prevention of the coronary heart disease? So because we know during the COVID time, we have extensively used these digital health tools, particularly on the mobile app and various other methods, so as to educate the patient and to teach them how to take the preventive measures and how to treat in such situation when he already sustained an acute attack of coronary syndrome. So what is your comment on using these digital health tools?
It's a very good question. We all know in India, in urban and rural area, urban and rural both, if we have a STEMI, patient doesn't understand it is STEMI. Start with that. Then he has to, if he understand, then he has to go to a close by center where ECG can be done and can be interpreted rightly.
Yeah.
because 10% of the thrombolysis is given in hyperkalemia.
Yeah.
So those patients are subjected to unnecessary risk of spontaneous bleeding. We know with thrombolysis, risk of spontaneous bleeding is very high. In our center, we take consent from the patient, written consent, before giving thrombolysis, that you can have a spontaneous bleeding in the brain and stroke. It's so important for all of us. Then third thing that is most important is digital tool. If patient has gone to a diagnostic center where technician is available, he has taken ECG, but he cannot interpret the ECG. You can use a tool to transfer the ECG to nearby ICCU, and you can transfer the patient for thrombolysis to begin with if cath lab capable center is not available close by. So maximum mortality, 65% of sudden death, sudden cardiac arrest out of hospital are due to acute MI. So if we only take care of acute MI through digital health, we'll be able to save lives and lives and lives. So in India, we have to develop first a proper STEMI network. So unless we have a STEMI network, we are not done. We are not done. As an association, we have a role to play there. And we want to do this, that we develop a STEMI network all over India, effective STEMI network. That is one. Second, adherence. For any primary or secondary prevention or rehab program, adherence is a big challenge. That's why I like inclisiran. Twice a year, just take a prick, and patient has to come. He cannot take orally. Patient has to come for a prick. So it's ensured that, okay, I can sleep now well, my patients are properly adhered to the therapy. Otherwise, I'm always under tension that I have done the PCI and my patient is taking DPT or not, I don't know. If he gets admitted with another event or thrombotic event, post-stent, then he will blame me, doctor, angioplasty has failed. And it is called as failed angioplasty. So we have several challenges, particularly in our country. We have other challenges that the affordability, the insurance. There are several social barriers in management of the patient. And the most important barrier is patient doesn't recognize, he tells it is gas. And if you do a ECG and tell him that it's acute MI, he says, you change the machine now, I don't have a heart attack. I'm fine. So this is a major problem. We need a public education system to the digital mode.
Yeah. That's
and
important.
Responsibility lies on Cardiological Society of India to educate people. In 75th year, we have to do this job.
Yeah.
Now educate public.
So you require more and more.
Because no matter how much academics we discuss, two of us sit down and discuss, if patients are not benefited, it has no value.
Yeah.
Community should be benefited.
I think with the passage of time, it will gradually increase the usefulness of the digital technology, particularly educate the patient as well as the public, so that they can take the measure. And as you have said rightly, that the ECG is done, but the reporting authorities, nobody is there at the time of crisis. So in that way, it will go a long run in future. And I think India will also touch to improve this digital technology application for both the primary as well as the secondary prevention of the coronary heart disease.
I have to tell one anecdotal story. We have had our colleague practicing as a cardiologist in Mumbai who had his own proper heart setup, heart hospital. So he developed chest pain. He went to his own ICCU, took the ECG, and he himself read the ECG, acute MI, because no other doctor was available at that time. He himself read the ECG and told sister, give him thrombolysis. So she gave thrombolysis. He developed VT
Post-thrombolytic.
post-reperfusion arrhythmia. He developed VT. Now he's not available to treat VT. He's gone in coma. He's not available to treat VT. He remained in vegetative state for 25 years. Recently he died. This episode occurred in 94.
So nobody was available to treat.
That is what in city like Bombay, his own hospital.
Correct. Anyway, so we have a very nice discussion today. So now I request the sponsor to say the final word to conclude this beautiful session of the secondary prevention of the coronary heart disease. Sponsor, please.
Yeah.
Anybody?
I'm here, doctor. So very good evening, everyone. My name is Preeti Mistry and I work as a general manager, sales and marketing for the Corazon division of Alembic. As you know, Dr. Alembic is a company which is touching lives of many patients over last 115 years. So at the outset, first of all, I would like to extend my sincere thanks to our honorable speaker, Dr. Vijay Bang, Dr. Nitin Kabra for the wonderful moderation, and Dr. P.S. Banerjee for this wonderful educational feast on the newer advances in the management of secondary prevention of cardiovascular disease using statin and DAPT. In fact, let me be very honest enough, Dr. Bang, your session was so insightful that I'm sure all of us who have logged in for this webinar would have been immensely benefited from it. Doctor, we as at Alembic would like to be in forefront in terms of disseminating the scientific information to the practicing doctors through such kind of webinars going forward also. And today for this webinar, we have a live relay. Your webinar has been relayed at 55 locations across the country, and put together we have almost 200 doctors attending your webinar, and I'm sure all of them have immensely benefited with the new drugs, the new therapies which have been discussed by Dr. Bang. I also take this opportunity to thank all the participating doctors who had taken out time from their busy schedule, have come personally to attend the program at the physical location, and those who could not make it have logged in to attend the webinar which has been arranged by CSI. So thank you so much once again. And then last but not the least, we believe that your opinion matters a lot. So our team will be reaching out to the doctors who are attending this program in clinic to take their valuable feedback, so that going forward we can really make a good progress in terms of improvising. How do we enrich the entire program for the practicing physicians? So thank you once again and have a great day ahead. Thank you so much.
Preeti, just 1 minute.
Yes, sir. Yes, sir.
Preeti, you are doing a recording of the program.
I'm not doing it. That's a CSI, sir. Yeah.
Whoever.
I'm not doing it.
You're not doing it.
No, sir, I'm not. It's a CSI.
You are just sponsoring. So
no, I'm just sponsoring it.
Technical support, please. Is there somebody from technical support?
Yes, sir. Yes, sir. Please.
So I want the recording of this program, please.
Sure, sir.
Make sure that you do it as early as possible.
Sure, sir. Tomorrow morning.
Because unless this is dissipated, 200 is too low a number.
2,000, sir.
No, 2,000.
I said 2,000 doctors across the country.
Okay,
so there is 55 location where the program got relayed, sir. And we have online. The doctors who could not make it, they have logged in. So in total, 2,000 doctors have been immensely benefited from the content of today's program, sir. That's a good number.
So technical support, what is your good name?
Sir, Kishore, sir.
Kishore, can you reach out to me? My number is with you.
Yes, sir.
So kindly reach out to me and give me the recorded